Alan just talked about the traditional treatment options, the different kind of procedures that we can do, the vertebroplasty, balloon kyphoplasty, and we can achieve good results with these procedures. Now we have newer concepts with directional cavity creation, ultra-high viscosity cement, directional cement delivery devices, intravertebral implants without cement, and non-PMMA cement. Of course, there is no ideal product. We just use combine different products for different cases to get the best result for the patients. So ideal would be effective, which we achieve with most of the procedures, safe and more biocompatible or osteostimulant implant, cement, the least invasive traumatic, and the least radiation to the operator and to the patient, simple and cost-effective. With the DFine product, we have experience in University of Arkansas, and we believe it gives us safe and simple way to reach our results with the ultra-high viscosity cement and very low radiation to us. Here are some cases that I'm going to present. Patient with T3, T4, and T9 fractures, minor fractures in the upper end plate. The important thing is about the directional cavity creation. You can see with unilateral approach with this articulated osteotome, you can cross over to the contralateral side, and with multiple directional moves you can create channels, and even you can combine them to create cavity, which will let your cement first fill into that area and expand from there to fill most of the bone. This is not sort of osteoporotic type of fracture on a myeloma patient, and diffuse filling can be achieved. Here's more advanced fractures, let's put it that way, and a patient with a plana at the T6 and other fractures at T5 and T8. The patient had previous procedure elsewhere, and and you can see some extravasation anteriorly. Not too much to cause any problem, but it's been hard to control the cement, as you can see here on this case done in previously. The osteotome basically you can get into tight places and basically create your channel, which your cement would be able to direct, and you can see you can turn it to a contralateral and unilateral side. And with that, you can have a very controlled filling of the cement and stabilizing the vertebral body. Here you can see the 3 levels fixed at that time. Lung cancer patient, a lot of them, they're going to be mixed lytic and blastic. There's not going to be large cavities most of the time. Here is an example of this case. Mostly sclerotic, a little bit paraspinal extension, maybe a little bit through, into the cavity, as well, into the epidural space. Here is on the X-ray, the needle placement. The cavity creator osteotome device is pretty sturdy, even for partially sclerotic regions, and you can cross it over to the contralateral side and create your cavity and fill it with cement. There is minimal leakage visualized here. This is controlled, and the patient doesn't have much of osteoporosis to have an additional level fracture here. A little bit, advanced techniques like we use in the aneurysms in the brain. You can try the balloon remodeling in a way if you need it, especially when myeloma just destructs and invades through the walls of the vertebra. Here's a T4 case. There is almost no anterior wall, very expansile, slightly pushing on the esophagus, and basic lateral wall is also missing. Partial, posterior wall is also gone. Here's different pictures of it. In the CT scan, you can see the extent of the disease. In the MR as well, hyperintensity. So here we thought putting a balloon anteriorly and slightly inflating it would have a better control than anything else to keep our high viscosity cement to stay inside the vertebral body without leakage. So with minimally inflated balloon and the cement very slowly over at least 25-30 minutes, the cement was delivered. And then after that, contralateral side was used to put more cement into the vertebral body. At the end, our balloon was stuck, so we couldn't take it out. We just basically broke and left the balloon inside the cement, which we have done in the past as well. With it dissolves, it burns out with the heat, and so this is the result. So anterior wall is controlled, posterior wall is controlled, and this is the end result on the CT scan. So with the very high viscosity cement, you can do a very slow injection, start, stop, and very small increments to control it and really not allow it to get out of the vertebral body. Here's another case in T2 level. This one missing the right side of the wall, partially also missing the posterior wall. You can see here. There's some remnants of trabecula inside the wall, so this is our standard extrapedicular approach. Get into the vertebral body. We broke through that trabecula to be able to reach to the contralateral side, and very slowly fill into the big cavity. You can see a uniform cement deposition, and this can be, as I said, can be pretty well controlled, and over a very long injection can be kept inside the vertebral body without any leakage to the paraspinal tissues or in the epidural space. As Alan showed, we can do pediculoplasty, especially for lesions involving the posterior aspect of the vertebral body with fractures at the posterior aspect of the end plate spirally and extending to the pedicle here. Our goal is to fill in underneath this fracture to have pain relief and also extend it to the pedicle. As you can see here, our approach. On these cases, we try to start from the normal side of the bone, anchor our cement there, and let it slowly bleed into the lesion so that we can have a much better control. Here you can see the cavity crater going in and making a couple of moves to make some channels, and if we can combine them, and after that start our cement and slowly let it move back, and when it reaches to the point, and here is a crack at the end plates, and we basically let it go a tiny bit and control it, stop there, and then pull back a little bit more, and then basically put cement into the pedicle, and so that fix the whole lesion with the fracture. This is a patient with an L4 fracture. One of the disadvantages of using the balloon, if you don't let the cement after the cavity creation into the vertebra integrate, the bone can fracture onto the balloon sometimes, and we see that periodically. Here is a patient who didn't have much cement after the balloons and basically fractured on it. Unfortunately, at this time, this wasn't done in an outside institution. At this time, a surgeon has seen the patient and done a posterior stabilization, and basically here we see retropulse fragment, 2 cement blocks there, and quite a bit of canal compromise. However, the patient didn't have any equina or any other lower extremity weakness. So for this patient, and you can see there's clearly a void in the center, and basically a motion in between the anterior and posterior segments of the bone. And unfortunately, posterior fusions a lot of times don't work on myeloma patients because of the loose bone, and the stabilization fails. So it's a very far lateral approach coming into the center of the vertebra and creating a cavity, and follow that very slow filling of the cement, and basically let it grow from the center to the periphery, which can be achieved with a high viscosity, very high viscosity cement. And this is the end result, and we stabilized also the upper screws, which had a new fracture at the superior end plate as well. And this is basically the result that we achieved. This patient has been pain-free for almost 18 months now. When there is multiple fractures, because of its simplicity and safety, this device can be used pretty fast, and can be done under general anesthesia if needed. This was a decompensated patient with who couldn't really breathe much, and we tried to do as many as we can in one session. So in 2 procedures, we treated 14 levels and tried to fix his whole spine, and just hit it very well. So this is the end of my talk. I'm just with ultra high viscosity cement, and we can achieve some dramatic results in very complex cases. Thank you.